Good afternoon, everybody. Once again, we're continuing our webinars on every Tuesday. We started a couple weeks ago, of course, talking about SpectraCell's micronutrient testing and how valuable this testing is for various conditions. And, of course, we gave an example of how that test comes into play with diabetes mellitus. And then for those of you that saw that one, and also last Tuesday, you saw how we connected the cardiometabolic panel that SpectraCell offers along with the micronutrient test. Today we're going to talk about, of course, the MTHFR testing that SpectraCell has available to all of you. But the important point is, once again, is how do we tie this particular testing into the micronutrient testing? I was talking to a doctor this morning on a consult, and she happened to, once again, do several testings, did the hormone test, did the cardiometabolic and the micronutrient test. And after I showed her how everything was connected, she even made the comment, she said, it's vital, isn't it, Dr. Grabowski, that we do the micronutrient test first and then we build off of that. And I told her that's exactly what everybody needs to do. And I think you'll see that today on how the MTHFR is a very common and sought-after test today, but how we have to know other things about the individual when we are doing this MTHFR testing and how it may play a role with other nutrients that are very, very important. So once again, I'm going to go to the point that emphasize that the micronutrient test that we originally talked about a couple weeks ago is based off of the lymphocytes, and of course this is the cell that is used for this testing. And how this test, once again, looks back 6 to 9 months of a person's nutritional status, and so it gives us a long-term evaluation. One of the ways that this is going to come into play today with the MTHFR is you're going to hear me talk about certain nutrient-nutrient interactions on how people are addressing the MTHFR, and if they don't do a test like the micronutrient test, that they will see that they may actually be causing some problems down the road that could more or less cause or present the same way that a person that has a mutation of the MTHFR. And once again, one of those examples that we, of course, associate with the MTHFR is anxiety or depression. We know that the methylation pathway is involved with certain nutrients that are strongly connected to anxiety or depression. And I'm going to show you how a nutrient-nutrient interaction that most people are jumping on to correct, or to, I should say, bypass the MTHFR defect or mutation, and how this could actually cause the same type of problem that you're trying to prevent. Now, moving forward, of course, as I mentioned the last 2 Tuesdays, that there are numerous things that we have to look at when we are deciding on what type of things are affecting a person's nutritional status or nutritional results. And, of course, we talked about the history and medications and diet and exercise and so on. But as you can see further down on the bullets, we see genetics. And this is where we're going to talk about today, is the MTHFR and how our genetic makeup, and even though we're just limiting it to certain nutrients, we know that there are a lot of research sightings out there that are looking into genetics and nutritional status. For example, we're looking at the vitamin D receptor and how genetics affect that receptor, and how some people may take a large amount of vitamin D and not actually benefit themselves as well as they need to be because they have a particular SNP that comes into play with, once again, that vitamin D receptor. So even though we're talking about the MTHFR today, this is just a small portion, but very important portion, of a role of genetics and our nutritional status or our future health, and how these genetic makeups from an early age, from birth, all the way until adulthood on how they may have this role. So once again, that's something that we're emphasizing today, and I'm going to show you how that connects to this particular testing. And then, of course, you can see right below that is the nutrient-nutrient interaction. And so those two topics today are going to be touched on as far as the genetic makeup and how when you try to treat or bypass a particular mutation, how nutrient-nutrient interactions come into play and actually have a big role. So when we are talking about various nutrients and we're talking about the MTHFR, of course, as you know, the enzyme that we're talking about primarily isolates or looks at folate and how folic acid goes through the methylation process and, of course, becomes methylated folate. And if people have mutation there, that how this is going to play a role. And you can see in this particular case study that this person displays a B12, a folate, as far as functional deficiencies, and then borderline deficiencies are the various B vitamins, and then some things like choline, inositol, vitamin D3, A, and so on with some of those other nutrients that you can, of course, observe on this testing. Now, to begin with, you might say, well, okay, what happens if I do this test first? Is there something that may lead me down the road to think that this person should maybe perform the MTHFR along with the micronutrient test? And of course, the answer to that is yes, that this person is actually displaying a very nice profile or pattern that would lead you to the road saying, yes, next time we test or maybe in the next week or 2 weeks, I want this person to do an MTHFR to see if they have any abnormalities as far as their genetic makeup, because they're giving me some warning signs or some indication that they may be poor methylators. And in this particular case, where we would see that is vitamin B12, the folate, the B2, the B6, and the choline. And so I'm going to show you this in a schematic later in the talk today on looking at this. So, of course, the folate's obvious that you say, okay, this person has abnormal folate, so maybe they're not methylating. But say that folate was not there, and maybe just the B12 and the other borderline deficiencies. There's still strong enough indication here that I would pull a MTHFR in this person. So once again, don't think that a person always has to have an abnormality with folate in order for them to be a candidate to do the MTHFR. The other thing is, what I see a lot in practice is patients come to me, they've already had their MTHFR performed, and right away, the clinician that's treating them is only giving them folate. They haven't looked at B12, they haven't looked at choline, they haven't looked at B2 or some of the other nutrients that are in the methylation pathway. And I think that's a significant downfall to that, and you'll see that when we get into the schematic that's showing you the methylation pathway and why we should be looking at all of these, even though, once again, we are directing most of our attention on the enzyme that, of course, is related to folate. And as you know, that the methylation pathway or process is in the second phase or phase 2 of detox of the liver. So when we are talking about methylation issues, one of the things that we always have to keep in mind is what's the ability for this person to detox. And I know some of you or maybe all of you are doing detox programs out there. And this is one of the things that we should be looking at is when you're doing the detox program, are you pulling an MTHFR and possibly a micronutrient test at the same time or prior to detoxing to see if there are particular nutrients that are going to play a major role in the detox process, especially phase 2 in the liver. So once again, this throws a lot of implications into the situation of the treatment. So when we look about methylation and we're considering MTHFR, there are certain nutrients, of course, that play a role in the antioxidant function, which is, of course, noted by the SpectraCell, and the immunodex, which is a immunological marker as well. And for example, in the methylation pathways, you will see that glutathione and cysteine both come into play in the methylation pathway. So when you see an abnormal SpectraCell, which of course is more or less an average or a summation of how this person is taking care of their free radicals or quenching their free radicals through the antioxidant pathways in the body, that a abnormal SpectraCell could be a very general marker saying there might be a methylation problem here, because we know that cysteine and glutathione are involved in that pathway. On the same hand, when we look at the immunodex also is looking at similar nutrients. We know, once again, that B6 has a big role in immunology with the lymphocyte, and that's in the methylation pathway. Once again, cysteine is involved in that, and glutathione is in that pathway. So when we are looking at both the SpectraCell and immunodex on the micronutrient test, they are being affected by some of the nutrients that are in the methylation pathway. Now, are they as sensitive or direct as, say, the previous slide that I showed you where there's B12 and folate and B6 and so on? No. That's a stronger indicator, but this is complementary to what we're looking at. So blowing up this picture of showing you on graph form on the involvement with this particular individual is that you can see that all of their Bs are not in very good status. For those of you that are new to this, once again, the patient's result is indicated by the little square in each graph. If the square is green, it's going to be in the white. If it's in the yellow, it's black. And, of course, if it hits the blue, it's red. And that's, of course, what we call a functional deficiency, where the ones in the yellow are what we call borderline deficiencies. I personally like to see all my patients squares up in the mid-white or higher. But once again, if that's the standard that I like to look at, you can see that this person's B vitamins are poor, that there is not any one B vitamin that's robust, and that, once again, we'd have to address all of them. Now, taking this in context with the MTHFR, you will see here that the B2, which is in the methylation pathway, is borderline deficient. Your B6 is borderline deficient. Your B12 and folate are functionally deficient. Then you go down to the next row, which we know serine is in the pathway. And once again, I'll summarize this again several times throughout this talk today. We know choline's involved in the methylation pathway, and you can see right there that that is a borderline deficiency. And so that would give us another indicator that there could be a abnormal MTHFR methylation pathway. Then moving on, or I should say blowing this up, you can see that it's clear that these are the ones involved. And as I talked about, taking my arrow here, and I'm using B3 as an example, is I would like that person's square to be right here or higher. So once again, for those of you that maybe missed the previous 2 Tuesdays, is the little crosses that make up the gray etching in each graph represents the last 3,500 to 4,000 specimens. Now, moving forward, once again, as I mentioned, the serine is involved in this particular methylation pathway and the choline. You will see as we go a little later into the talk today how certain hormones affect some of these. And we'll talk about that and what person or people may be good candidates for the MTHFR and why certain conditions that we talk about and everyday health care, why the medications may cause some problems such as stroke or blood clots, say DVTs or something like that, and how they may come back into this situation of methylation or even involvement with hormones and the relationship like homocysteine. So once again, it's very important that we correlate all of these and look at all of them together. Now, none of these right here really are in the methylation pathway. However, there is evidence out there today in research that vitamin D has a role with methylation or could be affected by the methylation pathway, even though it's not directly in that particular pathway. And I'm sure we will find other nutrients down the road that may be impacted by poor methylation. But the point is that we've seen several nutrients, the B vitamins, the serine, the choline, that are in that pathway and definitely are involved with this particular individual. And once again, if you did the MTHFR in an individual and you said, oh, this person has a mutation of the 677 or maybe the 1298, and you just gave them folate, I'm going to show you how you may be impacting them and causing some problems if you don't have other information at your hand. The carbohydrate situation, we will talk a little bit about diabetes and the MTHFR. Once again, as you all are aware, the MTHFR has a long history, and it primarily started in the OBGYN field and was associated with infertility, miscarriages, defects like ADD, autism. And so from that area, the OBGYN field, it's migrated to other areas, cardiology, endocrinology, of course, cardiology. So when we look at these various conditions, is how these particular nutrients in this pathway play a role with these various individuals, and why, once again, you may want to order this test either at the time that you see them initially and say, oh, you have a history that could definitely play a role with this particular testing, or you take some medication that could affect certain nutrients, and we want to make sure that we give you the right form of the nutrient, and or they may have a family history that says that they have a strong history of diabetes or ADD or depression or something like that, that definitely could be helped or treated with the proper nutritional supplementation. I'm sure all of you fall into this category just like I do on a regular basis, that we hear patients come into our practice from time to time, and they say, oh, yeah, I have fatigue, or I have depression, or I have anxiety, and I went down to this local pharmacy, or I went to this health food store and I bought a B complex, and when I took that B complex I didn't feel any better, so I figure it's not nutritionally related as far as my fatigue or depression or something like that. And for those of us that have been in the field for a while, we know that, once again, that if a person is a poor methylator and they're not able to convert or methylate a folic acid into the methylated folate, that they may not benefit from a supplement that, once again, has folic acid or has cyanocobalamin or something like that. So the whole point is that those that did not benefit, it's not that nutrition doesn't play a role, because we know it plays a role with fatigue and depression, anxiety, and things like that. It's, one, did they get the right dosage? Two, did they get the right form? Three, are they poor methylators? And there's no way, of course, any of us can look at an individual and say you are a poor methylator or not a poor methylator. And also, we have to talk about, is if just because one family member has a mutation, we know that not a sibling or even a grandson or granddaughter of an individual will have the same mutation, that they can be skipped over, or once again, these mutations or these genes may not be turned on. So once again, here's another example of some of the other nutrients that are borderline that I'm going to correlate with the MTHFR today and how they have to be complementary with one another. This is, once again, the SpectraCell showing you that there are three different levels. Of course, the blue is showing us that a person has poor antioxidant status. The yellow zone, of course, is average, or once again, a level that is considered by most people to be normal, when I say or common. And of course, we want the person to get into the white portion, which would be a very desirable status or situation of quenching our free radicals. The immunodex is the same thing. We want you in the white, like this particular individual, which shows that they have a strong response. This is the first 5 days of growth, once again, and this has to occur. If the person's white blood cells, their lymphocytes, do not proliferate, the test is not going to be able to be performed if they do not get enough cells. And this is when some of you might have received a letter from SpectraCell saying that this person did not have a good response. Now, I'm going to touch on this a little bit on how and why this may happen, and I'm going to touch on it when we talk further about the methylation pathway, because some of the nutrients that are abnormal in the methylation pathway as far as deficiencies, whether they're borderline deficient or functional deficient, has an effect on this immunodex. And this is something, it's a kind of a protocol that I discovered or developed a while back, and I found it to be pretty successful when we see a patient's results fail. So going into the carbohydrate page, or the second page, and we'll talk about carbohydrates and also the individual antioxidants, and this is summation, is the reason I'm bringing this up is this is a good example where this person on this page has an abnormal chromium, and they also have a glucose-insulin interaction. So we know chromium is strongly associated with insulin resistance. Now, as I mentioned, I'm going to correlate the MTHFR with other conditions today. And this is a good example on why we need to do testing, because you may read an article out there that says chromium helps insulin resistance and this person has type 2 diabetes, or alpha-lipoic acid helps insulin resistance, which is true, and both of those are true. But the point is, if you just treat those two and you just shotgun them and throw those at, how do you know you're covering all the bases? And once again, as I talk about some of these nutrients today, you'll see how they're going to interfere with one another and may actually push you into a condition with the patient that, of course, you don't want them to get into. So this is a summation, once again, of the micronutrient test and showing you if the person has borderline values, they're highlighted in blue, and if they're deficient, of course, they're highlighted in red, and that's more or less a summation of the previous graphs that I showed you. So now we're going to get into the MTHFR testing, and this is how this particular report is tested. You can see that we look at the C677T mutation. In this particular case, there's a homozygous, so there's two mutations on this particular individual. And then the A1298C mutation indicator shows negative, so there's no abnormality at this particular position in this particular person's genetics. The main thing I want to emphasize or point out on this particular page is because a lot of people say, okay, so there's a homozygous status on the 677. One, what does that mean, and how does this affect this patient? So if you look at the first bullet, you will see it says there, this is associated with a decreased enzyme activity of approximately 30% of normal activity. So this is the way I explain it to the patient. Of course, it's kind of elementary, but they understand it this way. Is let's use folate, and say I'm going to give someone, or someone needs 1,000 micrograms of folate to function properly, and they have this particular mutation, which means that they have 30% maximum of normal enzyme activity. So if I gave this person 1,000 micrograms of folic acid, that they may only benefit of 300 micrograms of that folic acid, that only about 30% of their folic acid is going to be converted or methylated into the methylfolate. Now, that's the maximum. It could be less than that. It could be 20%, it could be 10%, but, approximately 30%. So if the person does need, say, 1,000 micrograms to function properly, say they're suffering with restless leg syndrome, or say the person is trying to get pregnant, or say the person has a macrocytic anemia that's folic acid or folate related, and they truly need 1,000, and you give them 1,000 of folic acid, they're not going to correct their condition because they're only converting 30% of that. So that's the thing that we have to understand. And then if it's not converting it, are there some side effects of that conversion? Or if we keep loading a person up with folic acid, are there some adverse effects? Can we overmethylate? And the answer is absolutely yes. And I actually saw a patient today. She came in from another practitioner. She told me that she had abnormal methylation. She had a heterozygous for the 677 and a 1298. She was taking 2 methylated products. One had methyl B12 in it, folate, and B6. Another B complex that she had B6, B3, and folate. And when you added the 2 methylfolates together, it was around 7 milligrams or 7,000 micrograms. What's interesting about this, and this is what I was mentioning about overmethylating, that this person said since she started their second bottle, the second product that this doctor prescribed to her, that she felt like her depression/anxiety actually got worse. When she was just taking the first product that had the B6, B12, and methylfolate in it, it was only about 2.5 milligrams, so 2,500 micrograms, that she felt better. And so this was a good indication. So once again, she had been doing this for a couple months, and I mentioned to her some nutrient interactions, which I'll get into with you in a second, and showing that you can't just throw some methylated products at somebody and not know what other nutrients are doing. Because once again, even though you have a poor or an abnormal MTHFR, it may involve several nutrients. So going to the next page, you will see this is where it's blown up, and you can see an example of the 677 mutation of homozygous. Now, once again, you can see that by having this abnormality, this particular type of defect or mutation actually increases a person's chance of having elevated homocysteine problems, which of course increases your chance of a stroke, maybe a DVT, and generalized myocardial infarction or cardiovascular disease. And it's also showing you that if the person, say, had RA and they were prescribed methotrexate, that once again they would have difficulty with this particular medication as well. So the point is, let's kind of jump down a little bit to about the homocysteine and why this comes into play. Now, of course, a lot of people know that homocysteine does have a impact on the vasculature. Whether or not some cardiologists agree that it's a result of myocardial infarctions or not, or neurologists support that it may be a factor in a stroke, or vascular specialists may say it is or it is not associated with, say, a DVT. We do know that homocysteine elevations can be associated with osteoporosis. We know that homocysteine elevations have been associated with things like migraine headaches, neuropathies, and various other conditions. So the point is that by having an MTHFR that's abnormal, now the question is, do you want to go and look at someone's homocysteine to see if that's also being affected? Even though it says it's highly associated with this, once again, are you going to get an abnormal homocysteine? Because if you're dealing with a person that has osteoporosis and you're just treating them with calcium, magnesium, and vitamin D, and you're not addressing the homocysteine or the nutrients in the homocysteine pathway / the methylation pathway, then you may not fully be treating the patient. So this particular test, which a lot of people associate, as you know, with ADD and depression, anxiety, and even dementia, has larger implications in several other specialties. As I mentioned, musculoskeletal in the relationship, of course, osteoporosis. We mentioned about endocrinology, the diabetes. Of course, we know cardiovascular disease. We also know in this particular case that the person may have an implication on, Alzheimer's or dementia. So it's a very important test, but it doesn't just isolate or go into the OB/GYN field. It has several implications, and that's what I think is interesting, and I'll show you some of those as we go. So once again, you can see here, as you know, the MTHFR is an abbreviation for this particular enzyme right here, the methylene tetrahydrofolate reductase. That's the enzyme that, once again, is important and has to be functioning well in order to convert or methylate a folic acid product into a methyltetrahydrofolate product, which is the active form of this particular vitamin. So this just goes back further, talking about the 677 and the 1298 and the development of, once again, cardiovascular disease and thrombosis and the relationship of methotrexate tolerance. And once again, we know that that particular medication is used in rheumatology. So this would be a test that should be a very big interest to the rheumatologist. Once again, that is prescribing methotrexate for, say, something like rheumatoid arthritis. Now, here's a portion, and I say portion, it's not a detailed, some of you may think it's detailed, but once again, there's other branches, and I'll show you another kind of subset or branch from this particular pathway. But I want to point out here, because when you're thinking about nutrients that come into play in the methylation pathway, there's several nutrients that come into play and have to be evaluated. And once again, as I mentioned, one of the things that seems to happen when people are ordering MTHFR and they find an abnormality is they just give them, methylated folate. So by looking at this, you will see here that here is one example of the tetrahydrofolate, so the folic acid relationship. Here's, of course, vitamin B12 and its relationship. Here's choline. So once again, choline is looked on at the micronutrient test, just like the B12 and folate is. Then, of course, you look at your B6, you look at your cysteine, and you look at your glutathione. And then I'll show you in another schematic where some other nutrients come into play, where B2 comes into play and serine comes into play as well. The point is, you can see how the methylation pathway plays a role with homocysteine and how we can't just give one product like, say, B12 or B6 or folate to control homocysteine. That cysteine has a role, glutathione has a role, choline has a role. In fact, I've seen people that have an elevated homocysteine and the only abnormality they have is choline on the micronutrient test. But yet if people did what I call the big three, the folate, the B12, and the B6, and tried to supplement them, the person's homocysteine would not get lowered because the person has enough of those three nutrients, but it doesn't have enough of the choline. Here's another schematic showing you a little bit more detail per se. And so here's serine coming off here. And so you can see this is why serine is involved in this particular. And then we look at this FAD here. And this is actually a coenzyme that is associated with riboflavin. And as a result, this is where riboflavin comes into play. So when you look at the methylation pathway, we have to look at so many nutrients, and then I'm going to talk about the connection of other nutrients and how they can be affected. So let me give you an example. We know that oral contraceptives, primarily estrogen, can affect the status of folic acid or folate. We know it can also affect B6. There's some indication that it may also affect B2. Well, if we have someone that's taking estrogen therapy, it could be for osteoporosis prevention per se. Some people use it for cardiovascular prevention. And, of course, some people use it for headaches. Maybe they say, when they give estrogen, they may help a person that has premenstrual type migraines. Or it might be even in a case maybe a person has endometriosis, and so they're on some type of hormone therapy. By doing that particular medication or group of medications, that you may actually push someone into a nutrient deficiency that's in the methylation pathway. Now, if they already have a defect, a mutation, not only do you have to replace that particular nutrient, but you also have to provide it with possibly a methylated form. It could be methylcobalamin or it could be methyltetrahydrofolate. But the point is, a common medication for for female in the childbearing years, for endometriosis, for premenstrual migraines, or in the latter years for maybe osteoporosis prevention or cardiovascular involvement, may cause some nutritional deficiency that are involving in this pathway, and as a result, the person gets an elevated homocysteine. You get an elevated homocysteine because you've caused some deficiencies in this particular one or more nutrients, and now the person has thrombosis, or the person has myocardial infarction, or the person has osteoporosis. So once again, we have to look at numerous nutrients in this pathway, and yet I think a lot of people are gearing it in just in the folic acid or the folate. And so they're given products like Deplin in high dosages. And once again, in a few minutes here, I'm going to talk about how high dose of a folate, whether it's folic acid or methylated folate, can actually cause some detriment to us. So you can see here that, once again, this is the enzyme that everybody's gearing up towards, and we're looking at these mutations of, once again, the 677 or the 1298. Now, some of you may do the 23andMe, and once again, that involves a lot more possibilities as far as genetic mutations, and it's, once again, a very good test, but I find that sometimes overwhelming to patients. Patients, once again, when they do something like that, they're asking themselves, well, what can I eat? I mean, if I have this mutation, that mutation, this mutation. So once again, I think sometimes it's so encompassing that it's almost intimidating to these patients. Where a simple test like this that looks at two particular genetic factors and whether or not there's abnormal enzyme activity is some place to start, but also show these individuals that there's some conditions associated with this. So let's talk about this. As I mentioned, one of the things that has been associated with an abnormal MTHFR is, this pathology here is diabetes mellitus. Now, when people talk about, of course, diabetes, they always want to jump on the chromium or the vitamin D or the magnesium or even zinc, or sometimes B3 is in boy. But as you can see here, that there is some association with the genes C677T mutation and diabetic peripheral neuropathy. And once again, this was presented in this particular citation that I have on the slide. And we also see that there's a correlation of the retinopathy associated with as well. So the question is, if this person is diabetic, and these are two possibilities, which we know they are, diabetic retinopathy and diabetic neuropathy, is this person would be a good candidate, as far as a diabetic candidate, to have their MTHFR evaluated. Now, the important thing about this is two nutrients that are strongly involved in the MTHFR, the methylation pathway, I should say, are also commonly involved with a medication in diabetes mellitus. As you know, metformin has the tendency to cause a B12 and or folic acid deficiency. And as we know, that's one of the most common medications prescribed for type 2 diabetes is metformin. Now, it may be in combination with other medication, but once again, it's one of the more common medications. So to begin with, we know that metformin causes an abnormality or possible deficiency with B12 and folate. And now we know that there's mutations involved with diabetes that also have that strong connection of B12 and folate. So there's a couple reasons why it's important. One, not only does a medication cause two deficiencies that are in the methylation pathway, but the person may have a mutation that may also cause a couple of these morbidities. The point is that if you didn't know that they had these MTHFR abnormalities, that you may just push someone with B12 injections of cyanocobalamin, or you may give them oral cyanocobalamin. Say, you know what, I've given this person injections of cyanocobalamin, or I've given this person folic acid for the neuropathy or for the retinopathy, and they didn't seem to get better. We didn't seem to arrest that condition. The reason is they may have poor methylation, which doesn't allow them to fully utilize it. And especially if you go back to where I showed you that this person that has a homozygous 677, they're only converting at 30%. So if we need 1,000 micrograms of that folic acid to be methylated and be utilized at 1,000 micrograms or 1 milligram, they're only getting 30% or 300 micrograms. So that's not going to satisfy their biochemical needs, and they're not going to arrest or even decrease the severity of these two conditions, whether it's the neuropathy or retinopathy. Now, I want to jump in here for a second because I'm talking about folic acid and B12 and talking about the methylated forms of each of those B vitamins. One of the things we know that in the literature shows that when you take folic acid, and we see this, I see this clinically as well as even methylated forms, that when you take it above 400 micrograms a day, and some of the literature says actually 350 micrograms a day of the folate or folic acid, that you can actually cause a zinc deficiency. Why is this important? The reason why this is so important is because zinc, once again, has an impact on the person's insulin receptors and insulin production. And so when we're talking about diabetes, and we're talking about possibly giving this person a large amount of folate or folic acid, that how is that going to impact this pathology that we already have? And once again, it will. So we know that the zinc is instrumental for diabetics. And so here we're trying to bypass a mutation and try to do the right thing based on this, and of course, trying to correct the neuropathy or arrest it, and we're actually causing another deficiency that could be very detrimental to this particular individual. And as we know, zinc is essential for proper wound healing, and we know that diabetics have difficulty with adequate or normal wound healing, and so it could actually throw this person into a situation that they would be compromised. So that's where the micronutrient comes into play, that here you're going to give this person methylated folate or methylcobalamin, so two nutrients that are in the methylation pathway, and at the same time you may cause a deficiency. Well, if you didn't have a diagnostic tool like the micronutrient test, you wouldn't be able to pick that up on this particular individual. Another area that we always want to look at, of course, as I mentioned, with this particular methylation pathway, as I mentioned, the vascular or cardiovascular systems, and where we see that, once again, there's controversy, but some people say that homocysteine is definitely a possible etiology for myocardial infarctions. We also know that it's associated with DVTs and stroke as well, and how it's connected to homocysteine. In fact, I have a patient that had a myocardial infarction approximately 4 or 5 months ago. Cholesterol was normal. Everything was normal except for homocysteine. The homocysteine was significantly elevated, and even his cardiologist, after looking at all the lab work, after doing a stent placement in this individual, said, I agree with Dr. Grabowski that I think it was your elevated homocysteine that put you into this compromised cardiovascular rather than, once again, cholesterol or triglyceride problems, because he doesn't have any cholesterol or triglyceride problems. In fact, they drew blood on him at the time of the myocardial infarction, and shortly after that, and he had normal levels. But as I mentioned, his homocysteine was significantly elevated, and when we did a micronutrient test on it, correlated extremely well with it. As I mentioned about cardiovascular disease, most people talk about, of course, the plaquing or arteriosclerosis or atherosclerosis, as you can see here, and a couple citations here that riboflavin, of course, being a cofactor by the MTHFR and the methylation pathway, has been associated now with hypertension. So I think if I asked all of you prior to today's talk, how many of you feel or know or even think that riboflavin may play a role with hypertension? Most people today, when they talk about hypertension, they talk about nutrition, they talk about calcium deficiency, vitamin D deficiency, or magnesium deficiency. Very few people talk about a B vitamin like riboflavin and the role of hypertension. Once again, how do you know if this person does or does not have a riboflavin deficiency if you're not doing some type of testing for them? And this is why the micronutrient test is a good correlation or adjunct to this MTHFR testing, because we know if you found an abnormal MTHFR and that's all you found, what nutrient are you going to give them? If you just give them methylated folate, you're guessing on what may be affected. what other nutrients? Now, the form that we usually want in these particular individuals is riboflavin 5-phosphate. Now, riboflavin and pyridoxine, so B2 and B6, have to be phosphorylated to be in their active form. The interesting thing about that is magnesium is crucial for that phosphorylation process. So if a person's deficient in magnesium, you may take in riboflavin and you may take in pyridoxine in the form of pyridoxine hydrochloride, and that person may not phosphorylate that nutrient to actually get into the active form because they have an indirect magnesium deficiency or an underlying magnesium deficiency. So the point is you need to know what the magnesium status is if you're using riboflavin and B6, because are you going to put that individual into an active form of those two nutrients, or are you not, because you have maybe an underlying magnesium deficiency. Choline, as I mentioned, is also a nutrient that has to be looked at. Once again, you can see that choline, we know, has several different factors. It's very important during pregnancy, which I'll talk about here in a second, but also in sports. If you deal with athletes on a regular basis, choline deficiency is more common than you might think. Choline deficiency will definitely predispose an athlete to muscle cramps or spasms. I've actually seen people get removed from games on a regular basis because of choline deficiency and muscle cramps, and yet most of the time when people have muscle cramps, they think of potassium, sodium, and some of the other electrolytes, which are important to look at, but once again, this is a nutrient that's very important. Now, as you know, this used to be looked at as a B vitamin. It's no longer considered a B vitamin, but it is in the methylation pathway, and on the example, the micronutrient test, you'll look back, that person does have a borderline deficiency of choline. Now, let's talk about, once again, hormones and the choline connection. We know that estrogen is essential for this, and once again, we know that when a woman becomes pregnant, that estrogen is extremely important, and the reason is because estrogen is required to make choline. And choline, as you know, is very important for cell membrane integrity, but also for the production of acetylcholine. So the neurological development or function is highly dependent upon choline. Going back real briefly to talk about methotrexate. Methotrexate, that medication actually has a tendency to decrease choline status, and it's one of the reasons why we think methotrexate causes fatty liver is because we have a choline deficiency with it. So on a positive thing, that estrogen helps make choline, and once again, a medication like methotrexate can deplete choline. And you can see here that men and postmenopausal women also have shown to have elevated risk of choline deficiency because, once again, we know in a female when she hits menopause that her choline production goes down, her estrogen production goes down, which indirectly, or directly I should say, affects choline production. And as I mentioned earlier, there are different mutations out there, and of course you can see this PMT enzyme that, once again, slows down, also has a relationship with the estrogen and choline status. And you can see there's a large portion, almost 75% of women have at least one copy of the slow PMT, which of course is a predisposing factor for choline deficiency. And I find this very interesting because choline, as you know, helps make a product called cholic acid, which is a bile acid which helps emulsify our bile acids. And as a result, or emulsify our fat, I should say, and as a result may indirectly protect us from gallstones. And if you think about it, women have a higher incidence of gallstone than the men, and that may be one of the connections. Now, as I mentioned, there is a possibility, and of course there are some people out there that are much more knowledgeable and emphasize the MTHFR literature than I do, but once again, the point is that there is a possibility, and some of these experts on methylation and the MTHFR enzyme and pathway have shown that hypermethylation can be very detrimental. For example, like I mentioned with one of my patients, that I think she's over-methylating, and that's why her depression actually got worse. Here's a situation with male individuals. They've shown in research that if you hypermethylate of this particular gene, that, once again, there can be some abnormalities with the sperm function, and, of course, develop what we call idiopathic male infertility. So under methylation, or poor methylation, or hypermethylation can actually cause some problems. And once again, like I said, there are some experts out there on this particular pathway that can go into a lot more depth, once again, with time, because this is a very high topic today, and once again, in-depth topic that, once again, can't be covered in just a 1-hour session. So taking that into consideration, as I mentioned, I showed you some interactions that if a person takes in folate or folic acid, that they could, in large amounts, it could actually cause a zinc deficiency, which could cause problems. If a person has some medications that they're taking, like methotrexate or oral contraceptives, how they may compromise certain vitamins and minerals. On the other hand, estrogen is beneficial for choline synthesis. And so there's some pros and cons to some of these medications or hormones, but I think the big point that I want to emphasize today is we can't just look at folate when we are looking at the MTHFR. And if you are doing the MTHFR and you are not doing a test like the micronutrient test, you are not hitting or involving or evaluating all the nutrients in the methylation pathway. And if you would do the micronutrient test, you could also see that with supplementation of something like methylfolate, are you causing some problems with, say, zinc? Or do you have an abnormal magnesium on the micronutrient test that could lead you to down the road to an abnormal B2 status or B6 status because you can't phosphorylate those two nutrients into active form? So once again, 2 weeks ago I showed you the basics of the micronutrient test and how it correlated with certain pathologies. Last week I showed you the importance of the micronutrient test in cardiometabolic, and then today I've showed you the importance of the micronutrient test and the MTHFR. In the future, we're going to talk about other pathologies and how these testing procedures correlate with them and why you want to do an array of tests rather than just one particular test, because is there, once again, a genetic component that may affect your dosing and or form of supplementation? 2, what about the nutrient-nutrient interactions? What about the nutrient-drug interactions? And, of course, then we have to look at the overall balance of ratios of certain nutrients. So, once again, hopefully this gave you some more insight on why it is important and relative to order the MTHFR. If you do the micronutrient test or you've only been doing the micronutrient test, I think you can see by that particular testing that there may be some early signs of why you want to do the MTHFR, especially if someone has a B2, B6, folate or some of those other nutrients that are correlated in the methylation pathway, and vice versa. So there are some strong indicators for the combination of testing, and as you know, the more information you have, the better chance you can make the correct diagnosis and the treatment plan. So once again, I appreciate your time for listening today, and if you once again want to listen to this webinar again in the future, it will be archived, and you can once again relate to this webinar in the future for possibilities or correlations with certain nutrients we talked today. According to Jessica, we don't have any questions today, so as of this point, but if you do, please submit them as indicated on the webinar. And even if you don't have any questions today, if you think of some in the future, once again, you can contact your SpectraCell representative. You can see a phone number there and also email address. And I thank you for your time and attention and look forward to talking to you next Tuesday and in the future when we talk about different pathologies along with the various testing possibilities through SpectraCell. Thank you and have a good day.